So let's shift gears a little bit. Let's talk about really another amazing phenomenon that's happened over the course of the last 10, 20 years, and that is we talk about curing metastatic colon cancer. Now, none of us are doing it. The surgeons or our other friends in interventional radiology, et cetera, are doing that. And Tony, I'm going to sort of let you set the stage for us here. When thinking about patients with oligometastatic disease, and we're primarily thinking liver metastases here, how do you manage that? How do you do treatment decision making? What's the process in a great place like the Mayo Clinic to, get that patient to no evidence of disease?
So, this is an interesting subgroup of metastatic colon cancer, this whole oligometastatic group that has the potential for a cure, but also the potential to be disease-free for quite a while, meaningfully so. And that essentially has changed even the staging of colon cancer, stage 4 into 3, A, B, C, based on the fact that we know these behave differently. So for the liver metastatic colorectal cancer that travels to the liver is a unique disease because, again, as we know, the colon drains to the liver through the portal vein, so it could be the first stop before the cancer cell travels systemically. And so unlike other cancers where you have to use the bloodstream to get to the liver, this may be a direct metastasis. There may be other mechanisms, of course, but this uniqueness actually has led to thinking that this group of patients could actually be potentially curable through removing the liver that's involved, the portion of the liver that's involved, and even for some smaller tumors, applying modalities like radiofrequency ablation, or even there's emerging data with radiation SBRT. So those patients, and this is why it's so important for patients like these, meaning patients with metastatic colorectal cancer that have metastatic disease to the liver only, or also you can include the other oligometastatic disease, those need to be referred to a hospital or an institution that essentially has a multidisciplinary group that deals with these instances, because those patients have actually a 20-30% shot at a cure.
And I think the oncologists listening in right now need to understand that that's sort of our job to identify those patients. The radiologists aren't making this call, and it's not like the surgeons are reviewing these scans. We've got to know enough to identify and refer and use our team. Johanna, when you're seeing a patient and I know when I do this, I sort of get a warm feeling that maybe, just maybe, we're going to do something good here. Talk a little bit about the language, the discussion you have with a patient. Do you use the C word, the cure word? How do you manage that discussion?
Yeah, I do have to say that when you have this patient that comes in, they've got this new diagnosis, it's a tragic diagnosis that the patient sit in front of you, that they have metastatic colorectal cancer. And it depends, the strength of the language I use depends on how much liver disease they have. There's some people that are liver only that the highest likelihood you're not going to cure these patients. Then there's ones where you could potentially cure them if you give them good chemotherapy and they get enough tumor shrinkage, and then there's ones that you can cure right away. For the people who have this oligometastatic disease, where we think we might be able to cure them right away or with minimal chemotherapy, I use the C word. I mean, it's something to say, we're gonna try. We're going to try it. And I do give them the percentages. 25 to 30% of patients still have a chance at cure, because I think that helps with the motivation that they're going to see all these extra doctors, potentially have different tests done, MRIs, try to get that chemotherapy in for that chance at cure.
Yeah, so I even use this similarly to you if it's the bad side of things. I'll use the language of, well, the only way we know to cure your cancer, this is a brand new diagnosis, is surgery. And of course, the problem with that is then everybody wants surgery, right? And you have to sort of talk them back from that. So we do now, though, I think, use it. Alan, are you using the C word
I do
clinic?
use it often. I mean, what I'll tell patients, especially early on in their disease, unless if with peritoneal metastases or some huge metastatic burden, no. But the patient who has modest burden or oligometastatic disease, the way I'll frame it is our goal is to cure you until proven otherwise. And of course, one of the things I've learned is always to be honest with patients. That way you don't have to remember what lies you told them. and I think therefore you're always on you know what you said before. But the frustration, I think, for me and for probably each of us is in the practices we have, which are referral practices. when you see patients where there was an opportunity to make a big difference and it was missed.
Yeah.
And either too much chemo, these are patients you can't use too much chemotherapy in. You get fatty liver, you may not be able to do a resection. You don't do 12 cycles of FOLFOX, you need to look earlier. These are things that are very frustrating because if you miss that opportunity, that's where you make a big difference. And I agree with the numbers that have been used. About 25–30% of patients, you actually get that opportunity.
In the right setting. Let's be clear about this.
Yeah.
So, you know, a few Mets, maybe unilobar Mets responding to chemo. There's some publications if in the perfect patient, you know, 60% five-year disease-free survival.
At
So-
Memorial Sloan Kettering,
Yeah,
in fact,
and
as
Johns
well.
Hopkins. These are where you get your cures that way. But the rest of us a little more humble. Humility is a good thing.